Hi, everybody. I'm Julia Wall, Director of Education for the Michigan Parkinson's Foundation. I'm very happy to have and thankful Medtronic has agreed to support this program tonight. And I'm going to welcome Chelsea and ask her to say hello. We also have Phil from Medtronic. You want to wave to everyone.
Hey, everybody.
Chelsea, yes, say
Hello.
hi. And thankfully, we have Dr. Carol Wyant that is going to be speaking to us tonight about Medtronic DBS. So, Chelsea, would you like to introduce?
Yeah, absolutely. Thanks, Julia. Hi, everyone. Thank you for spending your Tuesday evening with us. Really appreciate it. My name is Chelsea, and I'm a therapy awareness consultant at Medtronic. So my role is to really be a resource for the community and help with bringing awareness to what DBS is, who it can help, and hopefully be a resource for you all and help put together education programs like this. With that being said, I want to also thank Dr. Wyant for taking the time to speak with us tonight. And I am going to pass it over to Phil to introduce himself and then pass it over to Dr. Wyant. Thank you.
Thanks, Chelsea. And thanks, Julia. Thanks to Chelsea for setting this up. I am Phil. I am your local rep for Medtronic DBS. I live in White Lake, Michigan, and travel to all of the centers that implant DBS and all of the physicians that program and do everything DBS in Michigan. I usually am somehow involved in. And I especially want to thank Dr. Carol Wyant for being here with us tonight. Dr. Wyant is a physician at University of Michigan. She's a movement disorder specialist. She's been on faculty at University of Michigan as a clinical assistant professor since 2016. And all of that stuff is great, but I love the way that Dr. Wyant delivers information, and I love the way that she cares for her patients and has a passion for using every treatment option to treat Parkinson's disease, including deep brain stimulation. And that is the subject of our talk tonight. And with that, I'm going to pass it over to Dr. Carol Wyant.
Thank you so much, Phil, and thank you, Julia, for putting this on. It's great to meet all of you and to be able to talk with you today about one of the exciting interventions that we have for patients with Parkinson's disease, deep brain stimulation surgery. So before I know that we have most people muted. If possible, I'd like to see your faces just for a few minutes because I'm going to take a short poll. And so I'm going to attempt to share just this one slide and then still looking at your faces. Okay. So I want you to raise your hand or wave if you are number one. Which statement describes you best? One, I know a little bit about DBS for Parkinson's disease and I want to learn more. All right, I'm just kind of flipping through. Okay, we have a couple hands. Good, and now the next statement, I'm seriously considering DBS for myself or someone I love, and that's why I'm here. I get any waves for that one? All right, I got a couple. Very good. And then I or a loved one already has DBS for Parkinson's disease. This will be great in case anybody wants to share at the end because they've already gone through this and some of their experience. Great. Thank you, Chris. And Greg. Greg, was that a hand I saw? All right. Excellent. Okay, so there may be other reasons that you decided to join today. So welcome. We're excited to have you. Now I'm going to do the tricky thing of trying to share my presentation. And you have to tell me what you see now. Do you see the presentation or do you see lots of notes? How about now? See a slide?
Yep.
Is that better, Julia? Okay, I wondered. Okay.
Yeah, sorry, I was on mute.
Okay, good deal. All right, so now we'll go ahead and get started. Now that we've kind of set the base for why people are here. And if you're here for another reason and you just want to learn more about Parkinson's disease and be better informed so you know a little bit more about where you're at in the disease and all of the different options that are available, that's great. Hopefully we'll also be able to answer that question for you today. So first, we did this poll. So we're going to start by just kind of going through living with Parkinson's disease and what are those symptoms, because that's a great segue to start talking about what is deep brain stimulation surgery and when should I consider it? What things might it actually help? What would I expect from this therapy? And then throughout this talk, we'll have kind of peppered in a few patient videos from Medtronic, which I think are great ways to kind of demonstrate the different symptoms that this DBS for Parkinson's disease helps with. And then at the end, we'll have plenty of time for Q&A. So I'm happy to stick around, answer any questions that you have, whether you're new to this or this is old hat and you want to share some experience with others, that'd be great. I'm happy to stick around for that. So we already talked about me, so we're going to move on. So this first one is a video of a patient, just a short clip of a patient that had Parkinson's disease and had DBS.
I don't hear any sound. Should we hear sound? Okay.
Thank you. Hang on 2 seconds. All right, what you're seeing is, as you saw him, he's shaking a lot and then his hands are nice and calm on his lap. We should share video. And this goes back to learning how to share audio. Hang on 2 seconds with me. Disable audio.
Think if there's like a couple dots at the corner, if you share sound.
Yeah, we should be.
I got emotional.
How about now?
You know what I mean?
Perfect.
I got to a dark place.
We're gonna start over. Sorry about that, guys.
So how are you feeling since the surgery?
After the device was implanted and they turned it on, we were able to find settings that worked for me right away. But it didn't really impact me, I want to say, until I watched the video where you could see my hand shaking, and then a few minutes later, nothing. And so seeing it in the video, I got emotional. You know what I mean? I got to a dark place. And I found myself, you look around and you ask God, like, can I get 5 more years? Can I get 10 more years? And you start to, bargain. And it just felt like an answered prayer.
So I think that video really shows very well some of the symptoms that DBS can help with and how it can make a dramatic improvement for some people in their quality of life. That gentleman, as you saw, as you were reading, it talks about how he had stiffness and slowness and tremors. And then even he could see a great response as soon as they turned on his stimulator. Now, that's not the same for every patient that we program, but especially if you have really disabling tremors, that is one of those symptoms that we often see a pretty dramatic response right away. So we all know that patients with Parkinson's disease are very different. It's a clear myth that if you have Parkinson's, you look exactly the same. Everybody has tremors, everybody's shuffling gait. That is totally wrong. We all know that everybody has a different experience with their Parkinson's disease, but the things that we're talking about today and the improvements in the quality of life for patients who have the stiffness, slowness, and tremor, so those main 3 features of Parkinson's, they can all have benefit from DBS. If it's the right therapy for you. It might not be, but for a lot of people it is. So what is Parkinson's disease? So Parkinson's disease is a neurodegenerative disease, meaning that part of your brain, the nervous system, is slowly dying away over time, and that's years to decades. And unfortunately, that part of that degenerative process affects the dopamine cells in the deep centers of your brain. Dopamine is a chemical transmitter. So that's something that your signals that the brain cells use to signal each other to communicate. And that dopamine is lost. And that dopamine is a really important signal for movement. Okay, so as you lose that dopamine, you have less initiative to get up, go, and move, and keep moving. Okay, so as you have lower dopamine, you move slower, move smaller, and even freeze. Sometimes can't initiate or keep moving over time. Some other symptoms that patients with Parkinson's can get, besides just the slowness and smallness of movement, which is called bradykinesia, is the tremor. And the tremor that's classic in a patient with Parkinson's disease is that rest tremor, where you're relaxing, doing nothing, and then you see your foot start shaking or your hands start shaking as you're just relaxing watching TV. That's that resting tremor. And then this stiffness that comes with Parkinson's, and that's called rigidity. A lot of patients as they get older, they have stiffness, and that's often always related to like aches and pains from arthritis and muscle fatigue. But the stiffness that we see in Parkinson's disease is called rigidity, and it's actually a sign that your doctor feels as they move you around on exam. So if you have bradykinesia, so the slowness and smallness of movement, plus a rest tremor or stiffness, then you have Parkinsonism. You have something that looks like Parkinson's disease. The most common cause of Parkinsonism is Parkinson's disease. Okay, so those key main motor features, everybody has some of them in different combinations. So how does that affect your daily life? Well, you can all tell me better than I can that we know it affects everything. If your movements are really small and slow, it makes it hard to even tie your shoes, to write. Your handwriting can get really small and hard to read. Makes it difficult to drink from cups, especially if you're shaking, or to even do tasks like using a knife, cooking a meal, measuring things. That can be very difficult for people that have tremors or this slowness of movement that causes almost like an incoordination of symptoms. So we know that early in Parkinson's disease, that when you have that Parkinsonism, when we give you back dopamine by replacing it with something like carbidopa, levodopa, or Sinemet, or a dopamine agonist like pramipexole, Mirapex, those medications, that you'll have a great response and that you won't have nearly as much stiffness or slowness, and your tremor often responds well. And so you can have a really good response, and it lasts oftentimes for several years, that great response to the medications. That's consistent with what we know from Parkinson's disease. Unfortunately, after we get about to year 4, year 5, the meds just aren't doing what they used to do. And that's because, unfortunately, Parkinson's disease just keeps progressing. And so we end up increasing doses of medicines, adding more to it, moving the doses closer together, and doing everything we can just to try and stay on top to make sure your body has enough dopamine to be able to move. Around that time, patients will also start to develop dyskinesia. So like weaving and bopping movements. I'm sure that many of you have seen Michael J. Fox and some of his more recent interviews where he's kind of wiggling around, or on some of his shows that he's started more lately. And so those are the dyskinesias. They come for everybody with Parkinson's disease. It's not toxic. It's not a problem, necessarily a problem with the drugs. It's a part of the disease that happens in these middle stages. And then often, as we're trying to increase drugs, push them together, add more things, patients will have side effects from the drugs because, yeah, they're good, but all drugs have side effects. So in addition to those dyskinesias and just feeling like your meds aren't enough, patients will also develop these things called motor fluctuations, where they take their dose, kicks in about 30, 45 minutes. They feel pretty good, but then 30 minutes before their next dose, they start feeling that tremor come on. They're a little more stiff and slow. It's a little harder to get up. Their gait's a little more shuffling. They take their next dose, another 30 minutes, they feel good again. These are called motor fluctuations, where you move into the on state, so meaning where your meds are working well. And sometimes you even have a little bit too much meds in your system, and then you get the wiggles. And then right before your next dose, they start to fade away, and those meds start to fade away, and we fade into that off state. Okay, so that's the fluctuations on to off to on to off. This is something that happens very commonly once we get into those middle stages of Parkinson's disease. So part about this, or the main part about this talk, is making sure that you understand that once you get into that middle stage of Parkinson's disease, where you have the fluctuations, where you have the extra wigglies, where you have just side effects from medications and they're just not doing what you need them to do, there are other options available, okay? There are options including medical therapies, like we have tons of different drugs that we can add and adjust pills. And there are some people that say that's what I want. I don't want to have surgery. And so we keep working with them as movement disorder specialists to mix and match drugs and find something that's going to work best for them in order to help them. But there are also pumps that can help infuse medications in different ways. There are surgical interventions that are available for these fluctuations and dyskinesias. There are surgeries where they burn small holes in parts of that motor pathway in order to help treat some of those symptoms like the tremor or the stiffness and slowness. That's what is labeled under the surgical intervention. Some of those are like thalamotomies, focused ultrasound, things like that. And then we have device interventions, okay? And devices are actual other devices that are implanted. And this is where DBS fits in, where that device is implanted and it modulates the brain. It doesn't burn holes or cause damage. It modulates the brain activity in that area in order to treat the symptoms of Parkinson's disease. So now we're going to shift focus from thinking about what symptoms you have with Parkinson's to what is DBS? So deep brain stimulation is a therapy that delivers electrical stimulation to the deep centers of the brain. That's why it's called deep brain stimulation. You can see here on this picture, these dashes, which are your electrodes that are deep down, tunneled deep down into the brain, into that circuit, that motor circuit for movement. Those wires are then tucked under the skin and under the skull. They go to a little battery pack in the chest, and this is what's programmed by your neurologist or movement disorder specialist. And then it emits an electrical current to modulate how all of those neurons are firing. So DBS it's not really clear how it works. It says on here that it blocks some brain signals. You know, what we know is that all of the nerves in the brain, that they connect and they work through electrical activity. It's a different kind of electrical activity. So if we put in our kind of electrical activity, it kind of changes how those nerves are communicating with each other. So it decreases activities of some and increases activities of others. But other than that, we don't really have a great why this works, but we know it does work, and it's worked for a long time. It's well established, it's very safe, it's very effective for treating those motor symptoms we talked about. The other thing about DBS is that it's reversible. It's not like those other interventions where they actually can burn a small hole in your brain in order to affect movement. It is something where if there's problems, you only have side effects and no benefit, you turn it off, or you can even remove it without any problem. So the myth that we will often hear from patients sometimes about DBS is that my medications are good enough, and I don't think that the benefit of DBS would be any better than what I'm already getting right now. And, you know, some of this comes from hearing doctors like me talk about, you know, we can only do what your meds can do. Okay, I'm sure you might have heard that when talking about DBS, that it only does what the levodopa does. But that's only partially correct. Okay, it will give you your best on time, meaning it can do, if your meds help you to be able to stand up, walk around, and do what you need to do during the day, the stimulator can do that and give you more of that time. So it doesn't just do what your meds do, it increases the amount of time that your meds work, essentially. So this is, unfortunately, there's a few other myths we're going to go into. I'm going to skip that one, skip the statement I was going to make. I'll reserve it for later. But the other thing that I want to say is that not only does it do what your meds do and give you more than that, so more on time, it also allows you sometimes to decrease the amount of medication. More commonly, there's two different sites in your brain where we can stimulate from. One of the sites allows you to reduce meds a little bit more than the other. That's not something that I always go into surgery telling patients, yes, we'll get you off your meds. I never say that. I say, usually I see people be able to decrease their medications over time. And that's what we see, is that there is a decrease in medications after this surgery. So if medication burden is a problem, that is another reason that we will do DBS surgery. Okay, so to kind of list through those things that the benefits from DBS surgery, it improves your motor symptoms. So that's stiffness, slowness, and tremor, and gives you more of that on time. It may allow you to reduce your medications. And for people that have to take their meds every 2 to 3 hours, that's a huge improvement in your quality of life, to not be tied to your phone to have that alarm ringing. It improves your quality of life in other ways, as well as it's something that is on 24/7, where not all of our pumps are. So let's talk a little bit about more of that on time. Okay, so we talked about fluctuations where the meds are on and then they wear off and on and then they wear off before the next dose. And that happens throughout those middle stages of Parkinson's disease. Early in the disease, patients will say, you know, I feel like it's wearing off, you know, just like a few minutes before or right as I take my dose, and then my dose kicks in. So it's really not that big of a deal. But then it's 30 minutes, then it's 60 minutes. And so for these people who are early in that stage of fluctuations, the studies show that even doing DBS early as an early intervention, that they can get more than 2 hours of better on time a day without those fluctuations. And then you look at the people who are later in the disease and who have had fluctuations for a long time. And sometimes meds just don't work at all, or they just turn off without any warning. These patients at that stage in the disease can sometimes get 5 or more hours of on time, again, back to them from the DBS. So this is not just a therapy that is for people who are starting to notice fluctuations, but also for people who've had fluctuations for a while. So I mentioned that DBS improves your quality of life more than just the being tied to the time that you have to take your meds. It also, there are other studies that show that it just makes you overall feel better. It gives you a better sense of well-being. Like we heard from that first video of that gentleman who was just really down about where he was at and what the course of his life looked with. And this gave him a whole new optimism. That is not unique. This is something that we do commonly see in our patients with Parkinson's who have the good response to the stimulation. It also can allow for improvement in your ability to do your activities of daily living. That means like getting up, getting dressed, showering, doing things around the house. Those things become easier. So if DBS is so great, and like I've been saying, why doesn't everybody do DBS? Why hasn't everybody had this? And so I think that part of that is we have to temper this really great things that DBS can do with not everybody's an ideal candidate, okay? And there are also some risks associated with it that people are just not willing to take. So some of those risks are associated with the surgery itself. And that's really the time of the biggest risk that you have to be aware of. And where some people just say, okay, yeah, that's not for me. So the risks with surgery are at the time of surgery, they drill a small hole in the top of your skull here, and they introduce in that tiny little wire called your electrode. As it goes in, it might hit a blood vessel, and that can cause bleeding around your brain. That's called a subdural hematoma. Subdural hematomas can cause seizures, they can cause headaches, they can cause confusion, problems thinking, balance problems. They typically go away, but it can take weeks, sometimes a few months before all of those symptoms resolve. Then if that electrode, if it punctures a blood vessel inside the brain, then it actually causes a small bleed, and that's a stroke. And so then you can get weakness on one side of your body, numbness or tingling, or problems speaking, or problems swallowing. That those symptoms will get better, but they will never go completely away. And so those are big risks. They're rare. They don't happen to everyone. About 1 to 3 out of 100 people will get them, but those are pretty big risks. And some people are just not about that. There are also risks that, you know, it's a device. It is an electronic system. It might break. A circuit might open. You might get a crack in something, or you might fall on it and bust it. There are many different ways that that it could go wrong. And then we have some of those complications too. So you might need a whole nother surgery. Or as things are healing, you might get an infection. And then that infection could spread along that wire and go to your brain and cause a really severe brain infection called like a meningitis or encephalitis. And so if that starts to happen, we have to take that whole system out to protect you. And so then it's like a wasted surgery. So I think we have to realize, you know, for some people that risk isn't worth it, but for others it really is. And those, while they happen, they're pretty rare, but good to be aware of as you're going into surgery. So the other things that can happen, you know, I hear, so neurologic complications are listed on those things that we have to be aware of as we're talking about surgery risks. So there are 2 things that keep you from being a candidate for DBS surgery just from a medical standpoint. That one of those things is that your memory is deteriorating or you have dementia, okay? Because we know that everybody with Parkinson's over decades, if we follow you, at some point will get dementia, okay? DBS, if you give it to people who are already on that progress, can push them into dementia faster. And so again, that's not a good place to be. It's not something that we want to happen. But also we know that stimulation for somebody who's depressed, it can actually make their depression worse. And some people can actually become suicidal. And so if you don't have well-controlled anxiety or depression, this might not be a good therapy for you. All right, and then you have to consider kind of long-term. DBS is pretty safe. I see people with pacemakers and other stimulators and other things. So now we've kind of learned to commingle with many different devices, but there are still a few peripheral stimulators that you wear on your wrist or wear elsewhere that might not fare so well with DBS. So that might be another consideration for some people saying, you know, this is why I don't want to do this. All right, so when should DBS therapy be considered? So I told you about things that you might want to consider as you're going through the evaluation for DBS, and some symptoms that it might treat. Now we're going to talk a little bit more about that and if you should be considering that. We're going to start by watching another video. So fingers crossed that our sound's going to work again.
You may not be able to tell, but Clint has Parkinson's disease.
My whole body moved all the time. I was just always going and moving and shaking.
Everyday tasks became more challenging and sometimes impossible.
Clint, how are you today?
My doctor told me about DBS.
She chose Medtronic, and we're very happy that she did.
Medtronic Deep Brain Stimulation is a personalized therapy that sends targeted stimulation to the source of the symptoms and can help control tremors, slowness, and stiffness associated with Parkinson's.
And the DBS also allowed us to reduce his medication burden.
DBS therapy requires brain surgery. Risks may include surgical complications, infection, or failure to deliver therapy as needed.
I'm not moving around, I'm not shaking.
I have my old Clint back because of the DBS.
If you or a loved one is living with Parkinson's, don't wait for your medication to stop working. Please visit discoverdbs.com/Medtronic to learn more.
Okay. So this leads us into another myth about deep brain stimulation surgery and other surgical options for Parkinson's disease, is that this is a last resort. I only do this when I get to the point where my medications have failed. And that's not true. And I hope I can convince you of that by the end of this section. So when is DBS surgery approved? Well, the FDA approves it for patients that have Parkinson's disease for more than 4 years. Why is that number? That number is there because a lot of things mimic Parkinson's disease. So a lot of things cause that Parkinsonism, so that stiffness and slowness, sometimes a tremor. And it takes that first 4 to 5 years of the diagnosis to really be able to see, is this really Parkinson's or is it something else that's mimicking Parkinson's disease? Okay, so we need that 4 years to make sure we've got the right diagnosis. Number two, it's approved for patients that with motor fluctuations. So it's not approved very early when meds are still working. It's approved for once those meds start to fail and aren't doing what you need them to do, or if you're just not tolerating them for side effect wise, or if you have like a tremor that is just not responding. Okay, so those are things, so that medication movement symptoms or medication side effects, that can be approved within a little bit shorter time window. But really we want to make sure you have Parkinson's and then make sure that you've tried levodopa. The third thing is, in order to get approved for this, is you need to make sure you have levodopa response. Why is that? Well, it goes back to that statement that I made, that the stimulator does what the medications do. Okay, so they are there to treat those same motor symptoms. And we want to see a response to levodopa. Response to levodopa tells us this is Parkinson's disease. Okay, it also shows you how much better can I get from treatment with this stimulator. And so seeing that response is really important, not just only to make the diagnosis, but also to give you some expectations about what might be better with surgery. And then you have to have something that's not being controlled by medications. And, you know, there's studies that show that this is helpful for people right after they start having fluctuations or right after they've tried just a couple meds. But what I'm going to tell you is after, and hopefully you'll hear me on this, is that my personal preference is what we like to do is we like to make sure you're on a good dose of levodopa. We've given it a good shot. We've tried adding at least one thing to extend it, make it better for you before we start considering surgery because of those risks that we outlined earlier. Not everybody follows that path, but that gets you through the insurance approval to get the DBS. So that's one of the other reasons why we'll do that. So here's a different graph, a way to kind of think about when is DBS best. Okay, so on the left side, you see this box that says you have your initial Parkinson's disease. And this is when your meds are working and there's no problems with fluctuations and your meds are doing great. Say you had a tremor, but it's responding really well to medications. That is not a time that you need DBS because your meds are still working and meds are lower risk than DBS. And then we have this section on the right side of the screen. And that's when we've gotten to the stage of Parkinson's disease. And this is typically 12, 15 years into the disease, where the non-motor symptoms of Parkinson's disease are much more bothersome than the motor symptoms. Okay, so the cognitive issues, the anxiety or depression, maybe even hallucinations or autonomic fluctuations, these things are the bulk of your symptoms, not the stiffness, slowness, and tremor. That you've kind of got under control. So then we've gotten to the point where we're getting more symptoms that don't respond to Sinemet or to these other dopamine medications. And so therefore those symptoms aren't going to respond to DBS. Okay, so what we want is we want you to think about DBS in this middle stages. So as soon as you start to feel like those meds aren't lasting and you're talking to your doctor about what can we do to make my meds better, one of the things they should start talking to you about is, there are surgical options in the next months to years. We'll see how you do with medications. So this is that window of opportunity where we can give you the most benefit for your Parkinson's symptoms with the with the longest window for that quality of life improvement. Okay, so what do you expect with DBS surgery? This will be a little bit of a reiteration, but we're going to start by transitioning now to the surgery itself and reiterating a few of those things. So what to expect with surgery? Well, the myth is with surgery is that it's way too scary. It's not worth the benefit. You have to, hopefully by the end, you'll see there's a balancing act. And for some people, that's not a myth. For some people, it isn't worth that risk because of something else. But for a lot of people, they're going to get a much better improvement in quality of life. And so it is worth the risk. And so what we know is that DBS is proven and that most people would recommend it. Okay, so I have though had several patients, I start talking to them about fluctuations and we've tried several different extending agents and I was like, there are surgical treatment options. And they're like, no, I know this person and they had this horrible outcome. And it always makes me stop and wonder, why did they have this horrible outcome? Was it that they went in, they had totally unrealistic expectations, like they didn't want Parkinson's disease anymore and the DBS didn't take it away? Unfortunately, that's not what DBS does. So that might be one of the reasons why people are unhappy with it. Or maybe it was because they really weren't a good candidate for the procedure. They already had some memory problems that just weren't identified and they transitioned into dementia. And so they actually looked worse after surgery than better. Or maybe it's because they didn't have somebody programming it correctly, or maybe the lead was wrong, or they had some other kind of complication. Okay, so there's many reasons for why you might see a poor outcome. What I want to tell you is most of them are avoidable by going to a tertiary care center. That's a hospital that has a program that does DBS consistently and frequently. Okay, that means you're going to get a good skilled surgeon that knows what they're doing and that has a good track record. Plus, you're going to get specialists that can tell you, oh, DBS can't do that for you, or oh, yes, this is how much better you can get with DBS, and be honest with you and help you make the best decision for you. So what I would say is we can't avoid all bad complications from surgery. Unfortunately, that's going to happen, but we can avoid helping you, like guiding you to make a bad decision, or we can help you make a really good decision that could improve your quality of life. So just because you know one person that's had a bad outcome, try to ask why and see, could it still be good for you? All right, so what do you expect from DBS surgery? Well, let's talk a little bit about this process of getting DBS. So once you go in for surgery, most of these first procedures are done inpatient, meaning you're admitted to the hospital. You have nearly an all day long procedure where they started out, a lot of times they put a frame around your head in order to help them make sure they're guiding that electrode to the right place. And then most of the time, surgeons will have you awake during this procedure. They'll put you in they'll make you comfortable so you're not like scared or freaking out as your head's there and they're drilling holes. They'll make you comfortable, but you'll be awake. That way, when they put the electrode in, they can test it and make sure it's helping with your tremor or helping with your slowness or your rigidity. And then once that electrode is in, The most of the time, surgeons will just close everything up and they'll let your brain heal for a couple weeks. Then they'll bring you back into the hospital. They'll put you to sleep for this part, and then they'll tunnel that wire underneath your skin into the battery pack in your chest. That's an outpatient procedure. You'll go home same day from that. But then they have to allow that completion of the brain healing process, and that's another 2 to 4 weeks. And then that's when you come back to the office of your movement disorder specialist or your neurologist, and you have programming. So in Medtronic, the leads, those metal wires that they stick down and in, are special leads. They not only deliver stimulation, so deliver that electricity, but they can actually focus that therapy, and you can focus it in an area and spin it around that electrode, so you can really target that electricity to exactly where it needs to be to help improve your symptoms but decrease side effects. In addition, this lead not only can deliver stimulation, it can also sense brain activity, which we'll talk about in just a minute. So the newer models of Medtronic IPGs, or the battery that we talk about, they're much more comfortable. Some of the older ones were quite large, quite thick. These are much thinner, much smaller, nicer profile for people who are thin and everything. And you can barely tell that they're there. It's very nice, much more comfortable. How long do they last? Typically, the new Percept devices last about 3 to 5 years. Some people can get longer, some people are shorter. It really depends on how the physician who's programming your device what settings you're on. Because there are definitely settings we can use in order to prolong the life if needed to. There's a special note down here at the bottom of this slide that talks about a rechargeable system. There is a rechargeable system. Right now, that rechargeable system does not use some of the special technology I'm going to talk about in a minute, but I did want to point that out there because some people say, you know what? I just want the stimulator and I don't want to ever have to have another battery replaced. The rechargeable is a great option. Okay, so what happens then? I've got the electrodes, they're connected to my IPG, I'm going in to see my neurologist. What's going to happen? So typically, or what I can say what we do here is that I have patients come in first thing in the morning off of all their medications so that I can see and test what do they look like without any stimulation, without any medications. And then I start adjusting their stimulator. I go through all of those different contacts on their electrodes and see which one works best for the patient. And then I set them on that stimulator, have them take their meds, and then just watch and see how much better they look. Okay, and that's their first setting. Okay, and then we monitor them every 2 to 3 weeks and increase stimulation a little bit, decrease medications until we get to that sweet spot where things are pretty even throughout the day. And that usually takes a couple months or maybe 3 months for most people, but there are some people where it takes a little bit longer to kind of finagle with programming in order to make sure that we're on without those dyskinesia. So here is a video of a patient, this doesn't have sound by the way, so of a patient who is off medications and off stimulation. And you can see he has a lot of problems walking. So what I would say, describe this walking problem as freezing of gait, where his feet are stuck to the floor. And then once his DBS is turned on, you see him has nice strides. He doesn't have any freezing. He looks amazing as he's going through this. Okay, so while this video is great to demonstrate some of the amazing results that we can see in patients with Parkinson's disease, I actually debated not including it because I don't want to give you the wrong impression. Okay, you've heard me say DBS helps with stiffness and slowness, tremors, and if you have side effects from medications, but we can still give you some benefit from it without the side effects. What I haven't said is that it's going to help your walking, your balance, or freezing of gait. And I haven't said that for a reason, because that's not what the studies have shown, okay? There are patients that they're great when they're on, but as soon as they go off, they get freezing of gait. That may respond. That's probably what we see in this video here, okay? The problem with freezing of gait is once it starts in the off period, it often starts to trickle into that on period. If you're having freezing in your best on state on medications, you will still freeze in your best stimulation settings. Okay, so that's why I never guarantee my patients that their balance or their walking is going to be better with the stimulator. In fact, there are some studies that show it's actually worse. Okay, so I debated leaving this one in here, but I wanted to show you, DBS can be really life-changing for some people. We just have to be careful and make sure that what you're doing it for, we're actually going to be able to give you the right benefit. Okay, so here's where it gets to the really cool part about the technology for Medtronic and what's different than other systems that are out there. So this thing called Brain Sense. So I told you that that wire that they stick in not only delivers electrical stimulation, it also senses the electrical activity of the brain and all those cells and how they're communicating. And so what you see in this top picture, this gentleman, he's walking really nice, and behind him is a nice even slope of a curve of electrical activity. And then you see he looks a little bit more Parkinsonian in the picture below him, where he's stooped over, has this shuffling gait, and this is where he's essentially having more bradykinesia or akinesia, meaning no movement, when he's more rigid. And then the brain starts to elicit or emit this peak in a certain frequency that the stimulator can pick up. Okay, not there when you're on, there when you're off. So this is pretty cool. This is pretty cool. So how do we use this? Well, we use it in multiple different ways for our patients. Okay. First, as a programmer, it's really cool. When I do that monopole review, I then set a patient on their new settings, and then I watch as all of those beta waves smooth out over time. So that's kind of cool. That's kind of the nerdy part of me. Now, for the patient, and where it's really cool and more applicable, you guys get this patient programmer where you can mark events about how you're doing during the day. So it helps guide your programmer or your neurologist how to adjust your stimulation. Okay, let me give you a real life example. I had a patient, they were on Brain Sense. We had been programming them for 2 to 3 months. And then the wife starts describing that at night, they would just kind of stand there, almost like they were frozen. And she's like, no, it's, he just stands there, can't move, can't figure out how to turn and get into bed. And I just have to, and we just wait and coach him through. And I was like, oh, I don't think that it's medication induced. So I made a special event button that said freezing. And I had her mark it every time that she thought that the patient was freezing. And then I compared those markings to that peak. And what do you know? There was no peak. So he was freezing from other reasons, either because he was really tired or he was cognitively impaired or something else, but not because his stimulation needed adjusted or he needed more medications. So that's one cool way that you can participate in helping your doctor fix some of your symptoms, is identifying, are these things that can get better with my stimulation or not? The other thing that I will use this for is watching that timeline. So when you come back, if you're on a sensing mode, I can scroll, or your provider can scroll through that timeline, and they can look and see how often are you having bad periods and what times of the day are they usually? Are they usually just one time of the day? If they're usually just one time of the day, then I'll actually just preferentially adjust medications during that one time of the day, tell people to do that, and then even things out that way. But if it's more common throughout the day, then I'll be adjusting stimulation up. So those are just some of the cool ways that you can use this Brain Sense technology in order to better target your symptoms and treat you more individually. Okay, so what about once we get the stimulator? So I get lots of questions about that. One of them would be, can I do everything I'm doing right now? Yes. Okay. So if you're doing it now when you're in the on state, you're going to have more of that good on time. So yes, you should be able to do everything you were doing before. I think this says something about talking to your doctor, because there are certain activities that are not safe. The one that I'm going to throw out there is swimming. There's actually been reports of patients that can swim before but can't swim after DBS. So that is something that you have to be very careful about, getting back in the water after a DBS surgery. But that's the only thing that I'll tell people not to do. All right, can I travel? Yes, of course. So I showed you that patient programmer that you will get with your DBS. Just you take that with you along with your identification card. You tell the people as they're checking you through security that I have this electric device, can use a wand instead. Very safe. The wand rarely turns off the DBS. If it does, you've got your patient programmer, you're turning yourself right back on. It's very safe to travel. Can I get an MRI scan? Yes. So Medtronic, as long as there's no problems with the electrical circuits going from the battery all the way into the brain, you can get a 3 Tesla MRI scan, and that's the most common MRI scan that you're going to need. And then can you check your DBS battery? I think I don't get asked that question much. I do get asked the question, can I control it at home? And I think that that's a discussion with your provider who is helping to adjust your stimulation. I typically allow my patients some flexibility, but I give them very specific parameters because it takes your brain time to adjust to stimulation. So you don't want to adjust it every day. You're not going to get that benefit until like day 4 to 5. So you really want to give your brain time to really adjust. Okay, so one last question that I will very commonly get as I'm talking to patients about DBS is, well, how long will it last? And this is also a very individualized question. Okay, so we talked about how patients can get this as soon as you start having motor fluctuations, or even really early if you just have medication refractory tremor. Or you can get it pretty late when you're having lots of fluctuations to really just decrease your medication burden and help those fluctuations. So when patients who are in that early stage, I can say, yes, we know that we can improve your quality of life for multiple years and that we can help control your symptoms and keep you active, which can delay some of those other walking and balance problems. And so we can potentially help you for a very long time with this stiffness, slowness, and tremor. If you're later in your disease and you're really doing this because you can't get on top of the medications, or you're taking them too frequently, or you just have so much off time, it's just controlling you, and you're further and already starting to have walking and balance problems, what I'm going to tell you is we can help you with motor fluctuations. We can help give you more on time. But those balance and walking problems are going to continue. They're going to get worse. And often you're also going to get cognitive impairment within the next few years, or more memory problems, or more anxiety, or something else that's going to become a bigger burden. Okay. And so, yes, this is still going to work and still going to decrease your meds and decrease your fluctuations, but that's not going to be the big feature in a few years. In a few years, we're going to be talking about a lot of other non-motor symptoms. And so it might not seem like it was quite as beneficial for as long as we wanted. The stimulation works for the motor symptoms. Okay, so I'm not sure I can reiterate it enough. We have to know what that stimulation is going to do in order to make sure that's the right thing for you. All right, and then the other things on this slide, they just talk about, this is, there's a few contraindications, like if you have a surgery, you can't have a certain kind of electricity or electrocautery and stuff like that. But please don't jot any of these notes down. Okay, if you decide to do surgery, you will have a 24/7 help center that can help you. You'll have a rep and a doctor who can help and who can liaise with your doctor about, or surgeon about, these issues. So no need to worry about this. Okay, so DBS, just from Medtronic, makes sense. It's personalized care. You can direct that stimulation right where you need it. You can sense what the brain is doing and make adjustments in order to make your life better. It's comfortable, and it's been around the longest out of any of these stimulators, and it's very trusted. So if at the end of this, I haven't hopefully not scared you away, but you're starting to think, oh, maybe this might be right for me or for someone I love, I just want to reiterate, DBS is safe and effective. It does improve your quality of life. It does a great job for those fluctuations, the tremor that's not controlled by meds, or the dyskinesias. It's very good for those things that it's designed for. It is an established therapy. It's been out there a long time. It's helped tons of people. It is highly recommended. Even if you've heard about bad things, it doesn't happen to everyone. And DBS is not a therapy of last resort. You can use it earlier in the disease in order to give you better quality of life, allow you to be more active, and so hopefully delay some of those other complications of Parkinson's later. So now, if you want to learn more, what can you do next? So if you're interested, you can pull out your phone, turn on your camera app, and scan that QR code that's here. That will link you into getting more information about DBS from Medtronic. You can also go to the Medtronic Facebook page, find centers that offer DBS in your area in order to talk more about it. But really, what I would encourage you to do is just start talking about this, the pros and the cons we discussed and the symptoms that you're having. And then at your next appointment, ask your doctor, is DBS an option for me? There are also multiple other centers that you can use in order to gain information, like the Davis-Finney Foundation, PMD Alliance, or you could even ask to talk with a real person. There are people out there who have DBS and would be willing to talk to you and tell you their story. They've lived it, so they're going to have a totally different take on this than what I might have, or what your doctor might have, or somebody else that you talked to who knew somebody who had DBS might have. So it's good to kind of get it from the horse's mouth, so to speak. But in the end, DBS, at the bottom, it says, DBS is not for everyone. This is a very individualized decision, and something that you should really have serious conversations with your caregivers, because it affects their life too, your doctors, your specialists, and really make sure that this is the best thing for you. Because not everybody has the same results, unfortunately. Okay, so this is the statement that is the obligatory statement, but I wanted to leave it in here. We've already covered all of this stuff. It just talks about what does DBS therapy do and the treatment options, what are some of the side effects that you can have or the potential complications from surgery. And then just a reminder, therapy is not for everybody, but it can be very good for certain people. All right, so I'm going to stop there, say thank you so much for listening and for your attention. And I'm going to switch over to the Q&A. So I'm just going to stop sharing so that I can see people's faces in case anybody wants to unmute in order to ask questions.
Can I just add one thing, Dr. Wyant? It's Julia again. I also, just seems like a perfect time that if you are interested as well, you could contact the Michigan Parkinson's Foundation as well, because we are actually starting a mentorship program, not only for just DBS, but Parkinson's. So we, if you're interested in being a mentee, please contact us. And if you're interested in being mentored, let us know, because we are building that program right now.
Great, thank you. Oh, that's wonderful. That's perfect. It's always better to go to somebody local. It's a little different. They kind of understand where you're coming from a little bit more. Wonderful. Okay, so I'm going to answer questions from the chat, but if you have any others, please unmute at any time. So what type of surgery did Mike Fox have? And then Chelsea correctly answered, he had a thalamotomy. Okay, so that is one of those surgical interventions that's a lesion where they burn a small hole in a part of his brain in order to control symptoms. And thalamotomies are most commonly used to control the tremor symptoms in Parkinson's disease. And that was done many years ago. And as she correctly stated, before DBS was available. Yes. Okay. Does DBS slow Parkinson's disease progression? So unfortunately not. It does not change the course of Parkinson's disease. Okay. It improves your symptoms, so therefore it improves your quality of life, your ability to do activities every day, but it does not slow down that degeneration. Thankfully, it also does not speed it up. Okay, so that's another myth that, you know, it'll push you into dementia and other things. That is not true. Okay, it is common for patients right after surgery to have a few more word finding issues, but studies have shown that those go away within a year. Okay, so that's why it's really important to make sure you kind of know where you're at cognitively before you go into this so that it doesn't falsely push you into dementia.
I have a question.
Yeah, please.
How many different brain stimulator companies are there?
So there are three main ones. Medtronic was the first. There's Boston Scientific, and then there's, all right, though, should be, is it still Abbott? They changed their name. Okay, sorry. Sorry, I'm not, it's not that I don't use them. They changed their name. And so I sometimes I pull out the wrong name. Okay, so there are three.
Is there any advantages of the other two over Medtronic?
It's an interesting question. You know, you'll have experts who will argue that. So they all have the directional stimulation where you can move the stimulation around the electrode now in order to guide it and focus it. None of them have any of the sensing technology. So none of them can sense how your brain is responding to stimulation or medications and then allow you to make adjustments from that. Now, Boston Scientific has a little bit more with like how you can maneuver the stimulation around the electrode, but a lot of the features with the newer Sensite technology, Medtronic allows you to kind of adjust different electrodes so you can kind of mirror essentially what Boston Scientific is doing. So there's like tiny differences in the different hardware. I think the other big area where it's a little bit different is we'll talk about the battery and how often you have to have it replaced. Boston really mostly comes with the rechargeable versus Medtronic, their Percept, the one with all of the Sensite technology right now, is not a rechargeable. So that's the other main difference.
I've heard that Medtronic is also working on the rechargeable option. Is that true?
Yeah, that is true. That is true.
How far away is it?
So I'm going to have to defer to Chelsea because I was told I'm not allowed to talk about anything that's not FDA approved. But
and neither is Chelsea or me. But we will let you know when it is.
So no estimates at this time.
It is under review by the FDA, and that's about all we can say. So we hope really soon, but we don't actually know completely.
And that's the rechargeable version, right?
That's the rechargeable.
So
That's
right
the
now,
rechargeable version of the sensing device. There currently is a regular rechargeable device that is approved that we've used since 2009. So that is available, and that's a 15-year device.
Can I ask a quick question on that? If someone were to get the Medtronic device implanted, and let's say that the rechargeable battery, the new one that's under FDA review is not approved, and you put a different one in, maybe just one that will last 3 or 5 years, could the next battery change? Would they be able to swap it out for the hopefully approved new rechargeable battery?
I'll let Dr. Wyant take that one. Go ahead.
Yeah, so a lot of times we are able to connect leads to different batteries. And yes, the hope is that this newer one will connect very easily, allowing us to continue to have all of the MRI technology available or MRI capacity available. Okay, so that's the big problem. So if you're thinking, oh, I like the technology in DBS from one versus the other, I wouldn't suggest mixing and matching. Okay, because that takes away your ability to get MRI scans. So please don't do that. Okay, it is an individual decision about what is best for you with you and your surgeon and surgical team. But it's a great conversation to have about why do you use this brand or why do you use this brand, or I heard about this sensing technology. How might that help me versus some of this other technology? It's a great discussion to have with your doctors.
now what happened with me was I had two batteries from my Medtronic in my chest, and one wore out. And the insurance company would not replace it with a rechargeable. So they replaced the one. And then like 6 months later, the other side wore out. I had to go in for a second surgery.
Yeah, unfortunately, insurance rules don't often make the most sense for patients. And I'm sorry, we do often have patients who one side will run out. We just feel like, why can't you just change them both, and insurance won't cover it until the other side runs out. So
Exactly.
it's not right. And I totally get that. And I'm sorry.
What's wrong with letting it wait until it runs out?
Well, you don't, it's so, I'm not sure I understood. Could you repeat the question?
Mark.
To me?
Yeah.
Oh, I didn't
Okay,
realize I was being heard.
Okay. All right. So I want to make sure that we hit all of the questions that are in the chat. So the other one says, I'm considering DBS with MRI under anesthesia. Is it more risk than the awake option? I think that depends on the level of skill of your surgeon. Okay. So general anesthesia is really only risky in patients with Parkinson's who have cognitive impairment. Okay, that's when we know that probably being under general anesthesia, if you've got memory problems, is not a good idea for you because it might affect your memory long term. If you are having DBS surgery, you shouldn't have memory problems. So just the fact of general anesthesia shouldn't be a problem. But if you're doing the whole procedure under general anesthesia and you have a surgeon who hasn't done very many of these, how are they going to know that they're in the right place? Do they have the right support around them? So that's where making sure you've chosen the right surgical center is also really important, okay? Because you want a surgeon who has lots of practice doing the type of procedure that they're doing and that they have really good technical skills and good outcomes. Okay, and you want people that are going to be able to speak to that and that are going to be able to help you with that. So is it more risk because of the general anesthesia? No, because you shouldn't be having memory problems at that point, but it's maybe a little bit more risky if the doctor is not familiar with that procedure because they can't double check your symptoms during a sleep surgery to make sure that they're well controlled with the stimulator.
One other thing is when I had my surgery done, my surgery was covered by my insurance, but the anesthesiologist did not accept it, and they tried billing me. Make sure that everybody on the surgery team accepts your health care.
Yeah.
Or they'll try to bill you.
Yeah. Unfortunately, sometimes in certain hospitals, those procedures are all kind of outsourced to different groups as opposed to all being under one system. So it is important to make sure you know what you're getting into as you start looking at having your surgery at the different surgery centers. Make sure that's a very good question to ask your surgical team. How is your anesthesia going to bill me? Make sure that they've run my insurance and that they're approved for this. Because you don't want to get stuck with a multi-$1,000 bill. All right, is there a way to find out how many procedures various surgeons have performed and how they had complications? Ooh, great question. You know, in certain states, there are registries where you can actually look at their surgeries that are listed and complications and things like that, but not in Michigan at this time. So I am not sure about that, to be quite honest. What I do, because I work in both Midland and I work down at the U of M, and patients will ask me, where should I have my surgery? Which surgeon should I go with? I'll tell them, you know what, you should probably just meet them and talk to them. Okay, because I don't know their complication rate. I can't find it. It's not a matter of public record. Okay, but you should meet them and make sure that you like them and that you trust them. Okay, because like I said, most of these surgeries, you're awake for it. So you want somebody who's going to be listening to you if you're concerned about something or scared about something, who's going to respond to you, who's going to be able to talk to you, who's going to be able to explain things to you before, during, and after, in case there's ever a complication. You want to feel comfortable with your doctors. So while your long-term management for DBS is with your movement disorder specialist or neurologist, you have to feel comfortable with your surgeon. And so some of that is about making sure that they have good outcomes, and only they will be able to tell you that at this point. But you should also feel comfortable with them. If they're not approachable, you can't talk to them. Maybe that's not the person you want to be in the OR with, or be having to call if there's a complication.
Okay, add to that too. I just have to say, because full disclosure, I was the DBS program coordinator for many years, over 20. I just want to say that I think it's very important that you do talk to the team, you know, like find out who is their coordinator, who is their DBS nurse, or you know, and I think really we're very lucky. We have many talented physicians in Michigan. I would hope would be very honest, but the team, it's not just the surgeon and the movement disorder. I really think it's a whole team effort that you will get a feel for comfort. Hopefully you don't go in for a consult and they say, yeah, you're a good candidate. Okay, let's pull out my schedule and get you on the calendar next week. That's a red flag. It's not an easy process. It's a long, very thoughtful process. And I think that going through that with a team, and because to me, and I'm not sure if you agree, Dr. Wyant, the hardest part about DBS is dealing with realistic expectations of the outcome of the surgery, which is hard when it's unknown sometimes. So that's my 2 cents.
Yeah, it's very true. And your surgeon and your neurologist might be like, yeah, look what we could do with this. Whereas the social worker is like, well, let's be realistic. Who's going to drive you back and forth to your appointments so they can make those adjustments, or help you set up the Zoom so they can make those adjustments, or the social worker who's going to really ask, like, how is your mood? Do you have times when you freak out and can't be still, that you really aren't going to tolerate the surgery? And without that team approach, sometimes we aren't able to identify who really are the best candidates that we can really do what we want the DBS to do, and who really we should just say no, because this could potentially hurt you and not help you. And so, so I alluded to it, I totally am on, from a Michigan medicine perspective, we think that this multidisciplinary approach is really, really, really important to make sure that our patients have the best outcomes and get what they want out of a procedure if we're going to put them through the risks of that procedure. But not all places are like that. I would strongly encourage you to find one where it's not just one person telling you go have surgery and then you have surgery. Please make sure that you've had the cognitive screen. Make sure you've had somebody talk to you about who's going to help you with things, because after surgery, when you have a brain surgery, you can't drive for a month. You shouldn't be lifting things for a month. So all of these things that you don't think about until you're given time to really talk to all these people. So consider multidisciplinary programs.
Hey, some things that you should be aware of is that you're going to lose all your hair. They shave your head.
So most
Not
of
always.
them, I was going to say, most of them are now just here as to where they're shaving. But, you know, maybe they shaved off a little more. A little generous.
Also, the frame they mount on your head, that's the worst part of the whole procedure.
Chris, when did you have your surgery? What
in
year?
2014.
Okay, very good.
Yeah.
We've come a long way, baby.
Yeah.
So,
There are people who don't use frames at all. They use different kind of ways to localize the head so that you don't have to have the pins like screwed essentially into the skin. Okay. Now that's all numbed. Okay. But it can be scary for some people.
It wasn't done with
really
me.
want to be very mindful of our time. And I think we skipped over one that Adele asked in the chat. Since Michael J. Fox had a form of DBS, can he change it to the company to get rid of head shaking? Michael J. Fox did not have DBS. He had a thalamotomy where they went in and they burned a lesion in his brain. So he doesn't have any hardware in his body to be able to connect to anything. So I know we talked about that a little earlier, Adele, but I just thought I'd jump in and answer that. But I think that we have a question, Brian McKenzie.
Yeah.
Yes.
Yes. Go ahead.
This is Christine, his wife, and I've got several questions, Doctor. First of all, you talked about the risks, which when you were listing them, they're pretty scary, but you didn't say what the percentages of the risk. I'm curious to know, are we talking about 1%? You said that 95% of the patients would recommend it. Does that mean 5% had issues? I'm not trying to conclude.
Nope, that's
that.
fine.
Right.
That's fine. From the literature, the severe complications, so those bleeds, seizures, and things, less, so like 1% up to at most 3%. Okay, so most of them, the more severe ones, are very rare.
Okay. My second question is, I'm a little bit confused because you talked about the DBS would last for 3 to 5 years, but then you talk about the rechargeable battery for up to 15 years. So can you have the DBS working for up to 15 years?
So
3 to 5 years.
Great question. Okay, so that I want to clarify here. So the DBS, once it's in place and the stimulation settings are working, it's going to control stiffness, slowness, tremor for more than 3 years. Okay, we'll see it control it for a long time. We have patients with DBS for 10, 15 years. They still have pretty good tremor control and can still have some good improvement for their rigidity and bradykinesia. Okay, but their quality of life is not as good because now they've started to develop the other symptoms of Parkinson's disease. Okay, so the stimulation works long term for those motor symptoms. It doesn't help the other symptoms that are not motor symptoms. Okay, so it is worth still getting a rechargeable because it's still going to be working for those motor symptoms for a long time.
Okay, understand.
Okay.
You talked about once you decide that the DBS is not working anymore, do they take it out? So do they have to go back into the brain and pull it out, or how does that work?
So rarely. Okay, so it's not hurting the brain, so it can be turned off. Now, the only times that I've seen it actually turned off is when it's actually in a wrong spot. So the surgeon put it in a wrong spot, so we just turn it off because it's not working at all and whatever. And then that time they might take it out and put it back into the right spot. For patients, when we get to those later stages of the disease, okay, it's not helping the balance and walking problems, but it's still helping tremor, stiffness, and slowness. It's still worth helping in, so you don't have to take medications more frequently. Those meds will still last longer. So we don't stop it. We don't take it out at that time. We just start focusing on other therapies and things that help those symptoms later in the disease. Okay.
Yep. You also talked about the necessity to talk to the whole team. I would just like to practically ask, you know how difficult it is to get an appointment with one doctor, let alone try to get an appointment with the whole team. I mean, to me, this just sounds totally impractical, knowing, and we go to U of M. Fortunately, we live in Michigan and we go to U of M. But I mean, my husband sees Dr. Chu. You probably know him. I mean, you book a year out. So how do you get to see the whole team?
Yeah, it's a great question.
Evaluate, is this the team I want working on me? It just seems very impractical to say that. And I'm just curious to know how you get around that issue.
Most multidisciplinary centers, so most centers that do a multidisciplinary approach where you have a team, so a neuropsychologist that does your cognitive testing, a speech therapist, a physical therapist, or other people that are going to evaluate you, your surgeon, they have one person who coordinates that. That was what Julia used to do. So she coordinated all those people and all those appointments. So once your doctor, your movement disorder specialist says, yes, this person is ready for DBS, then typically they tell that coordinator, and that coordinator takes care of scheduling all of your appointments and everything. I can't speak to all centers. I know some are really quick and will get you in really well within a couple weeks, and some people it's a couple months to get all of those appointments in, but they will coordinate all of that for you if it's a well-run center.
And I guess it's a red flag if it's not a, if they can't do that, it's a red flag that perhaps you need to find another center.
Potentially, yes.
Yes. Thank you very much. I really
You're
appreciated your presentation. It was very useful.
Excellent, thank you.
I have a question, goes back to the appointments. Does the adjustment, can it be done remotely, or I have to have an appointment?
Great question. So remember how I said sometimes patients want to adjust their own stimulators? So sometimes we give them parameters and then we put you on a video and we'll adjust it up or down through a video if we have to.
So it can't be done just from the hospital. The nurse or nurse practitioner or doctor can't do it. Just
there are there's many different ways that this can be done. Okay, so there are many people who are trained with DBS that are not necessarily movement disorder specialists. So example, in Midland, I have a PA, she'll sometimes do programming for me, or some of the reps will come in and I'll see patients on a video and the reps will help me by changing the adjustments to the way I want it. So there's many different ways to get stimulation adjustments now in the age of virtual technology. So that's where I'm gonna have to leave that one for you, but yes, there are ways to do virtual programming.
And then one more question about this: the device is not self-adjusting, right? You know, there's some peaks and
that is
whatever
correct.
events are happening. You know, there's no self-adjustment based on that.
That is correct. That is correct. This is all of these technologies that we use with the SenSight lead and with the patient events. Those are all to help your doctor still adjust it at this point.
Okay, thank you.
You're welcome.
When you talk about being put under during the surgery, are you referring to twilight?
Yes. Yes. So most patients, in order to keep them comfortable, will give you a little bit of a pain medication and a little bit of a conscious sedation. So you've all been like in a colonoscopy, hopefully at some point. Okay, so it's medication similar to that in order to just make you comfortable, not really pay attention. But then they're easy to decrease the amount of drugs that you're getting at that point so that you can be able to participate in the testing to make sure the electrode's in the right spot. So that's what we talk about when we talk about awake. So you're not completely awake, you are comfortable.
Greg has a question.
Yeah, I think we have time for one more question. Okay. So go ahead. Not Brian, but Brian's wife.
I don't want to hog if someone else has another question. Quickly, Doctor, I'm sure you've heard about these gloves that people are putting on, and we've seen this.
Oh, you're muted. Hello?
Ridiculous. Is that anything someone should consider also, or is it too early?
So gloves can be helpful for tremors, but the evidence that's out there is pretty limited at this point. Yeah. So unfortunately, a lot of those peripheral stimulators also might not work if you have an implanted device that's also emitting electricity. Okay, so just to be aware, that might be one of those things that might not work with DBS.
So you can't consider both of them at the same time.
Not always.
Yeah. Thank you.
The AI question. So that is a very interesting question. We will see where we go in the future. I can't wait to see. It'll be very interesting.
Some of your questions. Hello?
Yes, Greg, I think.
I've had mine for 14 years. I was patient number 97 at Mayo. Dr. Kendall Lee, I think invented the process. It was the lead doctor. And it was a 13.5-hour surgery. They had four neurologists in the whole session. But right now we're running into a problem. We got Humana insurance, and Jacksonville and now Rochester are saying we don't want Humana anymore for the battery replacement.
Yeah. So yeah, it's a tricky thing. I'm sure that though there are many surgery centers around that you can look around and find one. The battery replacements are not quite the tricky surgery that the putting in the electrodes are.
Right. We live up in Marquette in the Upper Peninsula, so there's not much up here, but we're going to Marshfield Clinic in Wisconsin.
Oh, good deal. All right,
And
I
if
know that
you
we're
want to
probably out
reach
of
out
time.
to me, Greg, you can reach out to me, Julia, at the Michigan Parkinson's Foundation. We could try and help you since we certainly have great relationships throughout the state and surrounding area. But with that, thank you very much, Dr. Wyant. Great
So
program.
quickly,
Thank you,
I'm sorry,
Medtronic.
Julia.
Oh, sorry. I was
Before
gonna
we
thank
before
Medtronic.
we conclude, so thank you, Dr. Wyant, of course. Let's say I'm on this call and myself or a loved one do not have a movement disorders neurologist, and we think Dr. Wyant might be a good one to see, or University of Michigan might be a good place to go. How would we do that?
So you have to have, so most insurance companies require a referral to see a specialist. So if your insurance company requires that, you just ask your primary doctor or your neurologist to send in a referral to the movement disorder group at the University of Michigan. For some people, they don't need a referral, so you can just call and schedule an appointment. We have, we just hired 2 new wonderful people who are also helping us with our DBS program, Dr. Heston and Dr. Spania, and they are excellent, in addition to Dr. Fern, who joined a year and a half ago. And so we have lots of openings. So yes, thank you very much, Phil. That was very kind.
And I'm glad you brought that up, Phil, too, because at the Michigan Parkinson's Foundation, we have a referral list as well. So that has like Dr. Wyant's clinic phone number on it and address and things like that. That's also available on our website. So if anybody has any questions, you can certainly contact us. So thank you again. Thank you, Medtronic, for sponsoring it. It's always good to see you. And thank you, Dr. Wyant. I hope to see you guys September 11th for our Veterans Disability, if that applies. And feel free to give us a call.
Yeah.
Thanks, everybody.
Great.
Thank you.
Thank you. Thank you, Julia.
Julia, just one last comment. I will let you know, I'll follow up with just some resources if anyone on the call wants that, including if you want to get in touch with a patient who's gone through DBS, have that one-on-one conversation. Sometimes that's something that you want to ask different patients, what their experience was, what the surgery was. So I'll follow up, Julia, with that information, along with the QR code that was sent in the email if anyone wants additional information. So look out for that email, but appreciate everyone's time and thank you.
The program is recorded and will be on our see what 24 years does to you, on the Michigan Parkinson's Foundation YouTube channel. So it will replay again, so you can go back and watch that or share with family and friends that need a better understanding. Thanks, everybody. Have a great evening.
Thanks. Take care.
Bye.